We hadn't gotten that before.
Perfect streaming.
Oh, come on, Vimeo.
Go to the page. Vimeo, uh-oh. Logged out for some reason.
Crap.
Which one is it?
Where?
Just log in. Right there.
I guess do I have to?
Go to live events. Just click through.
Okay, we'll see. Yeah.
Okay.
Oh, well, not yet. Not yet. Not till we
Oh,
see.
you're on nothing. So
Oh,
this section, right?
no.
Click the GFX and see what happens.
What do you think it was? Do you think it was the? I guess it was the.
Must have been the connection, yeah.
Yeah.
I don't know. Did Tom set up the connection in any way?
No, I mean it sounds like it was feels like it was my computer.
Might have just been the difference between like the wired connection and the wireless.
Yeah, but I've always gone wired. I mean it sounds like it was feels like it was my computer.
Might have just been the difference between like the wired connection and the wireless.
Yeah, but I.
Provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM mock points. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME outfitters will submit your mock points. Again, I'm Miguel Reguero, Professor of Medicine, Chair of Department of Gastroenterology, Hepatology, and Nutrition at Cleveland Clinic. I'm also the Pierre C. and Renee Bora Family Endowed Chair in Gastroenterology and Hepatology. And I welcome everybody from where I am tonight, which is Cleveland Clinic. I'm joined today also by my esteemed colleagues. First, let me welcome Dr. Marla Dubinsky. Dr. Dubinsky, as you all very well know, is a professor at the Department of Pediatrics, Chief of Pediatric Gastroenterology and Nutrition, and co-director of the Susan and Leonard Feinstein Inflammatory Bowel Disease Clinical Center at Icahn School of Medicine at Mount Sinai in New York, New York. Hi, Marla.
Hi, Miguel.
I would also like to welcome Dr. David Rubin. Dr. Rubin is a Joseph B. Kirsner Professor of Medicine, Section Chief of Gastroenterology, Hepatology, and Nutrition, and co-director of Digestive Diseases Center at the University of Chicago in Medicine in Chicago, Illinois. Hi, Dave.
Hey, Miguel, thank you.
So let's start with our first learning objective. identify predictors for treatment response and durable remission in patients with Crohn's disease. So Marla, can you start us off with this patient? Take it away.
Sure. So let's first meet Charles. Charles is a 33-year-old African-American man with sudden onset GI symptoms who presents to us for a second opinion. His main symptom is abdominal pain that he rates an 8 out of 10. He also has anorexia, nausea. He does have non-bloody diarrhea that could be as high as 5 times a day. He notes some weakness and some fatigue. He was on a 2-week course of prednisone, but his symptoms did not get significantly better, maybe for a day or 2. He does have a history of anxiety as well. His assessment included a hemoglobin of 11.4. His CRP was elevated at 18, upper limit being 5, C. diff negative, and the colonoscopy that was done prior to his course of steroids included aphthous ulcerations, cobblestoning, and skip lesions in the ileocecal area, and he had histologic findings of inflammation as well as actually non-caseating granuloma.
So great. So thanks, Marla. Let me have our audience get involved here. You should all see an audience response question on your screen. The question is, what would your next step be in the management of our patient Charles? Would you A, taper off prednisone, start methotrexate? B, taper off prednisone, start an anti-TNF with or without a thiopurine? C, taper off prednisone, start anti-integrin? D, taper off prednisone, start an anti-IL-12/23, or E, I don't know, tell me the answer. We'll review these results with you a little bit later in the program. So Marla, how do you approach IBD? I mean, what's your practice today in IBD? I know there's a lot of discussion about different targets now. We're evolving in our understanding, especially with Crohn's, beyond just inflammation to transmural inflammation. So how do you approach this? Go ahead and take us through this.
Yeah, so I'm going to talk to you about, introduce the concept that I do believe there are 3 key pillars of IBD care. First, we'll start with early intervention, and we'll talk a little bit about what that means and what you need to do in order to identify those patients who do need early effective intervention. Treat to target, as we know, this is a moving target. We're learning day by day as to new regulatory guidance, for example, as to how deep of a remission we're going to be talking about. We'll talk a little bit about what deep remission results in long term. And then, of course, tight control, which means in between, as you're trying to reach your target or in between target assessment, that you keep your patient in very tight control so that they are not having evidence or objective measures of disease activity in between. So let's focus on the concept of a window of opportunity. And where does this come from? This is one of the most famous slides that we all show when we're trying to emphasize the idea that we can have the most impact on the overall management of IBD if we actually use effective intervention early. And I think we do believe that the best window of opportunity is soon thereafter diagnosis. That definition has also varied. In Europe, they noted that maybe 18 months from diagnosis. I think we could redefine it to say that before any significant bowel wall damage that is irreversible has set in, which typically means fibrosis, muscle hypertrophy, collagen deposition in the wall. And the goal would be is that if you implement early intervention, a tight control strategy, checking inflammation in between, and a treat to target goal, then if you implement all 3 of those pillars, you're really going to forever change the natural history of inflammatory bowel disease. And I think we believe this for sure for Crohn's disease, where we have the most data. There is some discussion around ulcerative colitis that there may be bowel wall damage that also occurs, and hence this progressive bowel wall damage may apply also to UC. But most of the data, as we noted, comes from Crohn's. Now, one of the signature trials that I wanted to highlight tonight, which addresses all 3 pillars, which is early intervention, using biologic therapy early, using objective biomarkers to make your decision to dose adjust or escalate, with the goal of reaching a target of mucosal healing or deep remission. And that trial is the CALM study. That was published originally by John Fred Colin-Bell in Lancet, and then subsequently there was a longer-term follow-up to this study where Ryan Ungaro was the lead author, working with John Fred Colin-Bell, looking at what happens when you actually reach a target. So first, I'm going to walk you through the tight control aspect of CALM. Just as a reminder, a refresher on CALM, this was a study where patients were randomized to either have drug adjusted, meaning adalimumab adjusted to weekly, for example, from every other week, not based on symptoms, but predominantly based on calprotectin or CRP elevation, regardless of symptoms, versus patients who had dose adjustment, standard of care, using symptoms to dose escalate. And what they found is that there is a higher likelihood of being in deep remission at a year if we use tight control, meaning objective biomarkers, to adjust treatment. And this is just showing you the various criteria and definitions that differed between those that were in tight control versus the standard of care symptom escalation. What I want to more highlight is the idea that they then looked after those patients who got into deep remission, no matter how they got there, whether they got there by symptom escalation or objective biomarker escalation, that those patients who achieved the target of deep remission or endo remission had significantly lower progression of disease to needing surgery, hospitalizations, complications. Though the concept is that if we reach our target, our patients have better outcomes. And I think that needs to come with us as we look at other studies. For example, Dr. Shah, who was a fellow of ours at Mount Sinai, again with Dr. Colin-Bell, looked at a meta-analysis to say, is there a lot of data to support reaching mucosal healing as a target, not symptom control only, but actually an objective endpoint such as mucosal healing? Do we get a reduction in surgical rates? Do we also have long-term mucosal healing, which this slide shows you that no matter what outcome we looked at, which is clinical remission, surgical-free survival, and long-term mucosal healing, that when a patient achieves endoscopic healing at their first endoscope, their first treat-to-target scope, you will have better outcomes. So I think the story is becoming very clear that we really need to have better outcomes to discuss with our patients as our target, not just symptom control, because they will have a better longitudinal natural history. Now, in order to decide which patient I'm going to use early effective intervention, which translates at the moment in Crohn's to biologic use, it has to be that not everybody needs a biologic. We know that there are risk stratification guidance. The AGA, interestingly, quite a while ago, Bill Sambord authored a paper in 2014 suggesting that there are risk factors that render a patient moderate to severe or moderate to high risk of disease complication versus those that have low risk of complication, otherwise known as low severity versus moderate to high severity. And you can see on the left where it says risk factors for poor outcomes, it shows you some of the clinical characteristics of a patient that renders them at higher risk. What the publication subsequently had put out and also introduced the concept of tailoring your treatment, and Gary Lichtenstein published in AJG also highlighting that you could take risk factors and match a therapeutic approach or strategy or targeted strategy based on the risk of the patient. So if a patient is a low risk patient, there are certain therapies that we can use that we may be able to follow the patients and see if they flare. However, probably where the meat of the matter and where I think this discussion needs to focus is less on the 10-15% of patients that have these low risk factors, but why are we not focusing on the majority of our patients, sort of the 80-20 rule, where most of our patients do have at least 1 to 2 of these risk factors that would result in us using early biologic intervention. And that's sort of where this dichotomy went, where if you could start stratifying your patients early, you'll feel more comfortable applying a early effective biologic-based strategy. The future may include small molecules as new small molecules for Crohn's come out, but for the moment, we're really talking about a biologic versus a non-biologic based strategy. There's been a lot of attempts to sort of investigate whether there are other risk factors that actually highlight for us the type of patient we need to be paying attention to, meaning, all right, there's clinical risk factors that the AGA put out. We understand that, but are there other factors? And one of them I did want to highlight, which is smoking. And Miguel and I had a discussion around this, is that, yes, there are studies that propose that our treatments don't work as well in Crohn's patients who are smokers, particularly anti-TNF. But it's interesting, we're still trying to figure out what the role of smoking does have in prognosis, just in general across the board. You know, we've had a lot of discussions. We say Crohn's, smokers worsen Crohn's. In patients with UC, it's actually protective. I think we have a little bit more work to do, but what I do think is that it does impact treatment-related outcomes. Now, if we're trying to put this all together and say it's not just clinical risk factors, there may be other biologic factors such as serologic immune markers, such as ASCA or CBER, some of the what we call the serologic immune or antimicrobial-based antibodies, as well as NOD2, which is, as we know, the first gene to ever be identified as a at-risk gene for Crohn's disease back in 2001. And it has been shown in various cohorts to actually be predictive of more complicated or more fibrosis, more stricturing type of small bowel Crohn's disease. So myself and my colleague, Corey Siegel, along with his wife, who is a PhD in system dynamics analysis, which is a type of modeling, we actually wanted to see whether or not the predictor of outcome is improved in Crohn's patients by putting everything into a model. And being able to actually say whether there are both biologic factors such as serologic immune markers, genetics, as well as clinical factors that relate in poor outcomes. And here is introduced the Prospect tool. The good news is that this tool has actually been licensed by Takeda and will be offered to physicians across the country at no cost to the patient or to the physician. So Corey and I are very excited to bring this out into the clinic with the goal of being able to develop a personalized graph for your patient. So when you're thinking about how do I identify the highest risk patients, what do they look like? Is it possible that I can help identify up front those who would most benefit from an early effective biologic-based strategy? Now, so it's one thing to identify the high-risk patients, start to customize or personalize your treatment approach. The other is, once my patient is on a treatment, are there any tools that I may be able to use early, post-induction, to see whether or not my patient is going to have a better outcome over the year of treatment, for example. And what we know is actually fecal calprotectin has been shown to be a marker that if you have a patient who reaches a calprotectin less than 250 after induction at week 8, and both in Vedolizumab for both Crohn's and UC, that patient who had a calpro less than 250 at week 8 actually had better outcomes. So could it be that these early biomarkers may give me a hint into what the natural history of this patient will be? Now, there was also, based on both the UNITI, which is the Crohn's disease Ustekinumab trial, and GEMINI, as well as other cohorts of Vedolizumab studies. Perrenberg July really has been a leader in this in both the Crohn's and the UC space, and has really looked at the trials and said, are there certain characteristics that my patient who's sitting in front of me would be better served by using, for example, Ustekinumab and Vedolizumab before a TNF. And I know we'll get into the discussions further about sequencing and treatment choices, but I did want to let folks know that there are actually tools out there that may actually help you look at whether or not my patient would do better with this therapy, maybe first line compared to second line. So I think in reality, when we think about it, we have a lot of amazing tools that we could start to use to actually implement in and deploy in the practice as we speak. So in summary, and when you think about predictors of response and even predictors of therapy, achieving mucosal healing and clinical remission, we know, do improve patient outcomes in the long term with an emphasis on mucosal healing. Smoking cessation may actually improve the response to therapies. Low calprotectin or a drop of calpro less than 250 post-induction may help guide whether you need to optimize or escalate early. And really, at the end of the day, I think we're entering into an era where treatment decisions should be guided using available decision support tools. So thank you so much.
Great. Well, thank you, Marla. Actually, before we move away from you, there were a couple of excellent questions that came in, and I encourage everybody to send your chat questions in. One of them, Marla, is can we actually achieve mucosal healing in today's practice? Is that possible? I guess we're focusing on Crohn's disease tonight, so let's actually talk about that. What do you think?
Yeah, I mean, I do want to make a point about, when you ask me this question, I should highlight the COM data and to say to you that you could look at this study as glass half empty or glass half full, actually, because to be fair, only 45% of patients achieve that deep remission outcome with adalimumab escalation based on tight control markers. So the question is that as good as we get? I think we could do better, and I think we all feel we can do better. I feel that maybe, to be fair, for small bowel Crohn's disease, calpro and CRP may not be the best marker to actually, and you know what, the role of maybe point of care ultrasound and understanding more in real time what's going on in the transmural may be more relevant, one. Two, we don't have drug concentrations, to be fair, so I don't know. And three, patients were able to de-escalate, which I don't like because, you know, we all believe, I think once you're up, you're up. When the answer to mucosal healing, I think, lies in the SONIC trial, whereby when you took patients who actually didn't have irritable bowel syndrome at the time of entry because they had legit ulcerations, once we looked at the films, and CRP elevation, you're talking in your 70s of being able to achieve your outcome of interest and much better mucosal healing rates. So I think we could do better if we dose optimize and have the right way of monitoring tight control. I don't know if you agree.
Early, right, Marla? Your first pillar, getting them on therapy early may make a difference, although we all recognize the lag time between the onset of Crohn's disease and when they finally become symptomatic or get diagnosed.
Yeah, I mean, I will say Sonic and COM did focus on median about 2 years, so that was the good part about them. But when you look at our clinical trials, you can't apply that to real world. These patients had 7 to 9 years of bowel wall damage before entering some of our trials. So I do appreciate you pointing that out, Dave, actually.
Well, if we flip it a little bit and talk about not achieving mucosal healing, but preventing relapse after surgery, for example, where we know somebody's at risk, but they haven't had obvious recurrence yet, that's where we have the greatest success. So that might be the far extreme of a treat to target. It's the opposite of getting to the target. It's keeping at the target. And we're so much better in that scenario. Of course, not everybody needs surgery, but that's a segue into what we're going to talk about in the next learning.
And actually, Dave, before we go to that, we have questions are starting to come in, which is great. We're going to do 2 more quick questions. Dave, I'll ask you one, then Marla, end with you with one. So, you know, you both mentioned fecal calprotectin and the limitations potentially in Crohn's disease, but Dave, if you do check it in Crohn's and it is elevated, you have a colonoscopy and you see a change, meaning an improvement with therapy, it drops. How often are you checking fecal calprotectin? What's your guidance with that?
Well, let me start by saying that I'm a bigger fan of calprotectin in ulcerative colitis than I am in Crohn's. And even when it's elevated in Crohn's, if it's the typical Crohn's disease of the small bowel, it's less reliable. Having said that, in a stable patient, if I'm using Calpro, I would do it every 6 months once they're in stable remission. And that's not in everyone, but it's based on what Marla just taught us, which is the patients who are at higher risk for worse outcomes or higher risk for relapses. I've moved more towards serologic markers in Crohn's disease, whether it's a CRP or the combined serologic endoscopic healing index more recently. And I find that that can be helpful as well.
Great. And then Marla, final question before we move on. And then for the audience, we'll make sure to get to your questions at the end. But you mentioned risk factors in terms of certain risk factors for deciding on a biologic early. What are one or two kind of key risk factors that you look at that says, you know what, this patient from the start deserves a biologic?
So I think for me, the two big red flags is perianal disease. I've made the decision that that is a patient where you do not stop, you go straight to a biologic therapy, because the implications and the natural history of perianal disease is terrible. It is really to me, one of the most malignant forms of Crohn's disease is complex perianal disease, right? Patients end up with ostomies. It's just, you need to be aggressive here. You know, that's a red flag. My second red flag is actually depth of ulcerations. I have in my mind decided an aphthide doesn't mean it's penetrating. You know, you haven't gone below the mucosa. So I think the longer segment with deep ulcer is an immediate red flag. We know those patients are going to end up with higher surgical risk, and perianal. Those are my two main go-to. You've earned.
Yeah, no, I think that's good. I mean, I think that, you know, the fistulizing perianal disease, and I like the depth of ulcer. Deep ulcers are important. And it's interesting, we had a case this morning here where I talk about the two ends of the GI tract in Crohn's. So the perianal, anal rectal, and especially also those that have oropharyngeal or severe esophageal. Something about that is very severe, but deep ulcers and perianal fistula. So Marla, thank you. That was an excellent presentation as always. We're actually going to now shift gears and let's talk about appropriate targets for the treatment of effective Crohn's disease. So meaning, how would you effectively treat moderate to severe Crohn's? So Dave, tell us about a case and maybe walk us through this.
Sure, I appreciate it, Miguel. And obviously focusing on how to choose our therapies and how to sequence them is one of the biggest challenges we have in IBD. And in my opinion and many others, one of the areas for greatest improvement. So this is a patient named Elizabeth. She's 25 years old, and she's been referred to you because she's having persistent Crohn's symptoms. She was diagnosed with Crohn's of the ileum and colon 2 months ago and responded to oral prednisone. Currently, she's experiencing abdominal pain, nausea, occasional vomiting, and she has 4 to 7 non-bloody stools per day. On assessment, among other things, she has an elevated CRP at 26. You rule out infection for Clostridioides difficile, and you repeat an examination which demonstrates that ileocolonoscopy has focal deep linear ulcerations in the ileum and right colon, and spared transverse left colon and rectum, and no perianal disease. So let's say she's also had cross-sectional imaging, and there's not evidence of proximal dilation or obstruction. So here's what you have. And you heard Marla tell you what she thinks about deep ulcers. So which therapy would you recommend for Elizabeth at this point? Anti-TNF, whether it's adalimumab, certolizumab, Pagol, or Infliximab, any one of those. Anti-IL-12/23, Ustekinumab, anti-integrin, Vedolizumab, or you're not sure, and we'll come back to this. And we're not going to show you the answers right now, but we want to get your initial impressions regarding these therapies. So in choosing our therapies, Marla's done a great job introducing the concepts, and I want to drive home a few points. The first one is obviously we want to assess how sick the patient is right now. That's disease activity. And that includes not just what the bowel looks like and what some of the serologic labs look like, but also additional factors like extraintestinal manifestations that may be active. The other point is you want to assess what that patient's prognosis is. And you understand that there are certain factors that put our patients at higher risk. And Marla's introduced that concept. But it's important to keep this in mind because Crohn's disease and ulcerative colitis are chronic conditions that require chronic therapy. So our choice of therapy, while we want to focus on getting them well quickly in the beginning, also has to consider what we're going to do in the long term. The second reality is that we don't always know which therapy is going to work. Unfortunately, the big gap in our care has to do with the inability to obtain either a serum test or a tissue marker, or maybe someday a microbiome marker that tells us which therapy or which immune pathway is dominant, as opposed to which one might not be dominant. So we're left trying to use our best clinical judgment. And unfortunately, we're sometimes left based on the issue of what will be paid for, or what can we get. The third issue, of course, is efficacy and safety considerations. This is where a shared decision-making model and conversation with the patient weighs in. So we have a conversation about, here's what we think might work best, and here are some of the safety considerations. Don't forget that any conversation about efficacy and safety, or risk and benefit regarding therapies, must include the context of the disease progressing, which is also a risk, and that has to be part of this conversation. And then, of course, there are other issues related to whether you think the drug might be cleared more rapidly. Men clear more rapidly than women. More extensive or a larger burden of inflammation may result in more clearance of some of our monoclonal antibodies. And there are other issues we should be aware of, such as adherence or other factors that are going to help you. And then lastly, and I'll show you some data, we also understand and appreciate that in clinical trials and in the real world, the first therapy usually has the most likelihood of being successful. That is not because of a biologic phenomenon necessarily, that after one therapy doesn't work, it's changed the biology of the disease. It's much more likely that in our clinical trials, people who've been on other therapies before they get into the trials have already declared themselves as more resistant or having a more difficult disease to treat. So when we choose our induction therapies, we have a number of different considerations. Obviously, it's going to be based on how active the disease is, how sick the patient is, as well as the risk is of the patient having progression or ending up with complications from their Crohn's. One of the questions that we now raise, and we understand can be appropriate, is surgery best at the time of diagnosis? Based on what I already mentioned earlier during the Q&A, is it possible that this patient, by the time they present to us, has already had Crohn's long enough, or has had an aggressive type of Crohn's long enough, that they already are suffering from a complication, or more fibrostenosis or obstruction or penetrating complications? The study I referenced there is called LYRIC, and yes, it is spelled with an exclamation point, but the LYRIC study randomized patients with newly diagnosed Crohn's who weren't obstructed to a laparoscopic ileal resection or Infliximab. And at the end of a year, they found that their remission rates were similar, but cost of care and quality of life related to the Crohn's was better with the surgical option. So that is something that we should always keep in mind. Surgery shouldn't be your last option. Then, of course, we have to think about some of these factors related to monoclonal antibody clearance. Larger BMI leads to increased clearance for a variety of different reasons, maybe because fat is also an immune organ. Men, as I mentioned already, clear antibodies more rapidly than women. A high CRP or a low albumin is associated with increased clearance. And remember, too, that if a patient has already shown you that they develop anti-drug antibodies to one therapy, they're going to be more likely to develop them in subsequent therapies, especially in the anti-TNF class. So you have to think about all these factors when you're trying to choose your therapies. In addition, in the general principle in oncology, in dermatology, and now in IBD, we've started talking about using more organ-selective therapies before systemic ones when we can. An example might be budesonide before oral prednisone, or a therapy that targets the gut preferentially before we use more systemically active therapies. And then, of course, we think about other factors like what worked previously, what might we have available to us right now, and should we stay within a class, which is called cycling, or should we switch classes, which is called swapping? And then lastly, and I think very importantly, although it ends up being a smaller percentage of our patients, but having coexisting rheumatoid arthritis or psoriasis or a spondyloarthropathy or psoriatic arthritis or even diabetes might influence your choices of treatments. Maybe you need to avoid prednisone altogether, or maybe you want to make sure you're choosing a mechanism that's going to treat the other disease. So let's go through some of the treatment recommendations that have been published in the guidelines. Looking at moderately to severely active Crohn's disease, there are a number here, and they're color-coded because we'll come back to this when we talk about maintenance. But this is induction. Induction of remission, which predominantly means improvement in abdominal pain, reduction in stool frequency, and a variety of other factors that I'll touch on in a minute. Oral steroids are available as an option, but only for short-term use in getting rid of signs and symptoms and as a bridge to steroid-sparing maintenance therapies. Anti-TNF, of course, is available as an option, and we do have 3 available anti-TNFs, including a variety of biosimilars to Infliximab, and they have been recommended for steroid-resistant disease or thiopurine or methotrexate refractory disease based on their label and based on the strength of the evidence. When Infliximab is used based on the evidence available that I'll remind you of in a moment, it is recommended that this be used in combination with a thiopurine, at least initially, and especially in naive patients. And we can talk more about that. Maybe there'll be some questions and Miguel can guide us through that. Vedolizumab was recommended with or without an immunomodulator because of its low immunogenicity, but also recognizing its safety profile. And natalizumab, you may remember that drug, which is approved for Crohn's and multiple sclerosis and not used very often, is still available and is an option when we've really needed it. And more recently is Ustekinumab, of course, the monoclonal antibody against P40, which knocks off IL-12 and IL-23. And the guidelines say that you can use this in patients who failed steroids, thiopurines, methotrexate, anti-TNFs, or in anti-TNF-naive patients. So moving on, let me remind you why it's recommended to consider combination therapy of Infliximab with a thiopurine. This is because of the landmark study called SONIC, which was performed in patients who were naive to biologics and naive to thiopurines. And they were randomized to azathioprine, Infliximab, or the 2 drugs together. And I'm sure you recall that combo therapy was better than either single therapy arm in this trial. And that was looking at a specific endpoint of steroid-free remission at week 26. We've learned a lot more about SONIC since then. One of the points I want to make is that the safety of all 3 arms was similar. The risk of having infusion reactions was highest in the monotherapy Infliximab arm, not surprisingly, because those patients also had lower Infliximab concentrations and therefore were more likely to trigger an immunogenic response. And we've now learned in post hoc analysis from SONIC that actually the Infliximab level is most predictive of response rather than necessarily just being on combo therapy. So some people who are able to assess intra-loading or post-loading Infliximab levels can avoid combo therapy, or perhaps after combo therapy has been used for a while, we can consider removing it if we feel strongly that our Infliximab level is stable. Can you extrapolate the SONIC results to other anti-TNFs? Well, the data are not that strong to do so, but in general, given immunogenicity of our other therapies, we usually do, and I do in my practice with anti-TNFs. So moving on, we also have talked about Marla's first pillar, which is treating earlier. This is now an older study where we used a claims database to look at how people with Crohn's disease who were treated earlier with anti-TNF were more likely to have positive outcomes. To be honest with you, the story behind this study is that I predicted that the people who were getting anti-TNF earlier back then, and you can see this was 2012, were people who were probably too sick. And my hypothesis was that top-down therapy back then was going to not be as effective as we think because these patients were sick enough for the clinician to give them the drug up front. I was actually wrong. What the study showed is that the people who got anti-TNF early were less likely to be on continuous steroids, were less likely to lose response to their anti-TNF therapy, and maybe most importantly, they were less likely to have a Crohn's-related surgery. So one of the early studies with a large number that suggested treating earlier had better outcomes. If we go to the next slide, this is from the Mount Sinai School of Medicine in New York, where Marla is. And you can see our colleague Ryan Ungaro did an analysis more recently that demonstrates that any biologic therapies initiated early in patients with Crohn's disease actually reduce 2 other very expensive outcomes, hospitalization and emergency department visits. So the message is strong in the real world, and the message is strong in those controlled trials that we're sharing with you, that treating earlier actually gives you better results. So I think, Miguel, you just published some additional information about surgeries after biologics. Do you want to share that with the group?
Thanks, Dave. Yeah, we actually looked at a population-based approach, a population-based data, and we found actually a decrease in surgeries. So surgeries in general in one analysis, and then at ACG, we actually just presented our data on colectomies for ulcerative colitis. But if we focus on Crohn's, we actually found a 10-fold reduction in Crohn's-related surgery by starting biologic therapies early in the course, which really speaks to your alteration in the natural course of disease. So not just the data you presented on utilization, ER and hospitalization, but I think now we're seeing definitive evidence of alteration in natural course and decrease of surgeries in Crohn's disease.
Do you remember how long your follow-up was in that analysis?
Yeah, so the study, the patients, the median time in this study was 11 years. And then there was a wide range, so there were some limitations given the population database. However, these were patients who were followed for a long period of time. So it wasn't just new diagnosis and within 6 months. The other caveat, or the other thing that we interestingly found, was over time. So the earlier years of the study where biologics were less frequently used, we saw a significantly higher rate of surgery. And then as we saw the trend toward an increase of biologics, which included Ustekinumab, Vedolizumab, the anti-TNFs, we saw a significant drop. So interesting data. We need more, but I think we're seeing pretty compelling evidence.
Yeah, but that odds ratio of 10-fold reduced likelihood is really strong. And, you know, our surgeons have said to us, hey, are you not sending us patients anymore? And I've said, you know, I think our therapies are actually changing the natural history of the disease. So for our colleagues out there, you may be thinking, okay, there's a lot of information here. How am I going to know what therapy to put my patient on? Well, if it's not immediately obvious, there's also a way to move through therapies. So Marla nicely showed you the CALM study, which was a tight control study, but gets at this second pillar of what she spoke about, which is treat to target. And if you look at this cartoon, what you can see here is after you choose your initial therapy, you should reassess to know whether or not your patient has achieved a target. In Crohn's disease, the consensus statement that was published in 2015 says it should be elimination of abdominal pain, reduction of stool frequency, and some objective measure of mucosal improvement, whether it's endoscopic or cross-sectional imaging that shows that improvement, which is done more often in Europe and Asia necessarily than here, primarily because of cost, but it's completely reasonable. How long do you wait before you reassess the target? 3 to 6 months. In my world now, I'm doing it earlier, like 3 months. And Marla showed you Calpro drops as early as 2 or 4 weeks. So you want to assess that target. And when you don't achieve it, you're going to make adjustments, which is often just optimizing the first therapy. Sometimes it means adding something else. And occasionally, yes, after adjusting a couple times, we might jump to a completely different class. Of course, this is all in the conversation with patients, as well as your ongoing monitoring, the third pillar of what Marla spoke about. So once you get to your target, don't let go. This isn't somebody you push out to sea. You're going to then want to make sure you have a monitoring strategy. And I really emphasize every patient needs their own monitoring strategy. So you can see that you don't have to use necessarily just the composite target in the upper left here. It might be some of these other targets that would be reasonable for your individual patient. Maybe it's extraintestinal manifestations that are disabling. In children and adolescents, of course, it should be growth and development. And there's a newer version of that STRIDE consensus that Marla and I are part of. And I think Miguel is going to be part of this as well, that suggests that we should be using Calpro and some other things as are proposed here. So now moving on, after you've gotten through that induction phase, of course, is the issue of maintenance. And your options are sometimes determined by what worked in induction, right? Thiopurines are not for induction. They're too slow. And maybe there's still a role, although Marla will remind us that she hasn't been using them for many years. But they still have evidence for their use, and they're still cost effective in some parts of the world. And for immediately steroid responsive patients, they may play a role. Remember that methotrexate is an option for maintenance in Crohn's disease, and it's predominantly for those who were steroid dependent in that New England Journal article from years ago. And it might play a role, although there's some limitations to its effectiveness as well as its tolerability. Of course, anti-TNF therapy remains a good option. The guidelines suggest that if you're going to use anti-TNF, you should combine it with an immunomodulator. Vedolizumab is an option if you've used Vedo for your induction therapy. Natalizumab still remains an option, but if you're going to continue that therapy, you do check the John Cunningham virus antibody status every 6 months. And I'm sure for most of us, that's not something we're doing regularly or considering that therapy. And of course, Ustekinumab is a good option for those who respond to it for induction. So moving on, just to remind you, one of the things that's been talked about is whether Vedo is not as effective in Crohn's as it is in UC. And I just want to show you that one of the pivotal trials for Vedolizumab very nicely demonstrated superiority over placebo with nice clinical remission response, steroid-free remission, and durable clinical remission rates in the maintenance phase of the study. In addition, as I've mentioned a couple times, Ustekinumab is our newest therapy. You can see the very nice results here. And in the Ustekinumab-IM-UNITI trial, it included patients who had been exposed to anti-TNF, and this therapy worked quite well. And you can appreciate the magnitude of the results here. I wanted to introduce another study that is being presented or was just presented in its entirety at UEGW. I only have the initial part here, but I can tell you a little bit more about it. STARDUST is essentially like CALM, but using Ustekinumab, with the idea that patients could be treated to achieve a specific target, which was endoscopic improvement and endoscopic remission, a very large phase 3b study. What you see here are the data after 2 doses of Ustekinumab, the IV loading dose of 6 mg per kg, and then the first maintenance dose of 90 milligrams at the 8-week mark. Subsequently, after the patients had received those 2 doses, they were then allowed to either be in conventional management with the option of dose escalation if the patient's symptoms warranted it, or what they called the treat to target arm, where they could be escalated based on what endoscopy showed and what other markers showed, all the way up to every 4 weeks with the therapy. So before we get into what those results actually showed, and we're going to wait for that to be fully published, you can see that after 2 doses of Ustekinumab, getting back to what we've talked about, 37% of the treat to target population had already achieved endoscopic response, and 11% had achieved endoscopic remission. So obviously you'd like to see those higher in the ultimate world of managing these patients, but it definitely gives us more data, and we'll be talking a lot more about what we learned from STARDUST in the days to come. Now, moving on to drive home one additional point that came up earlier before I summarize, is that we know that positioning these therapies does matter. As I said earlier, when we see patients in the clinical trials who have already been on anti-TNF and have failed the therapy or been intolerant to it, or just come off for other reasons, they're less likely to respond to our newer therapies. Now, it doesn't mean they won't. You can see very nicely with Usta and Vedolizumab here that they work better than placebo, but the TNF-naive patients consistently do better in these trials. And I think that really pushes us to think carefully, which therapy are we going to use first, and how can we optimize it to make it work as long as we need it? So to summarize learning objective number 2, I want to emphasize treat to target is one way for you to move through your therapies to make sure you're going to induce remission successfully in your patients with moderate to severe Crohn's disease. We obviously have multiple choices, and we don't necessarily always know which treatment to use, but I've given you some clues along the way here to think about which drug you might use first, and hopefully reassured you about some of the data regarding how these treatments work, as well as how they will work better when they're positioned earlier. Back to you, Miguel.
Great. Well, thanks, Dave. Actually, I'm going to ask you one of the many, many questions we're getting. So thank you. Keep them coming. But since this is such an apropos time to ask this question, for small bowel Crohn's disease, and when you talk about tight control and monitoring, there was a question about small bowel ultrasound. But I guess a bigger question is, how do you monitor small bowel Crohn's? How do you apply the treat to target or tight control approach to small bowel Crohn's disease?
Yeah, I think that's a very important question. And I hinted at it. And then, of course, Marla will comment on ultrasound because she's now doing it. But what I use is a benchmark of their scope or a scan with a CRP if the patient makes CRP. And I mentioned to you that endoscopic healing index, which might be something new to many people who logged in tonight. It's 13 different molecular markers of mucosal integrity that's been validated in Crohn's, published in Gastro. And it's a serum test that can be ordered through one of the companies, and that can also be used in some patients. So whatever you're going to use, you want to know that it lines up. I do Calpro occasionally for small bowel Crohn's, but not as often anymore with these other options. Ultrasound's a good option. It's been validated and studied now in Europe extensively, and of course in Canada as well. Correlates to response to therapy, so you can use it that way right at the bedside, and also demonstrates a good prediction of recurrence after surgery. And Marla's leading the way now at Sinai doing this in her clinic, and we're hoping to do the same.
So Marla, maybe just very briefly, how's that going so far?
Sure. I just want to comment that I think what Dave was saying is part of it is he's talked about personalizing your tight control. So what I do is I do everything at the beginning, CRP, Calpro, scope, try and get everything at the time where I have an objective benchmark. And then whatever correlates to my scope, that's what I use, if that makes sense, because you don't have to do all of them. I will say I started to uptake on the use of this endoscopic healing index, and it has been helpful to monitor my patients, and CRP is part of it. So it integrates CRP among other things. But regarding my obsession with small bowel ultrasound, so yeah, my first ever paper in 1998 with the late Ernie Seidman was using Doppler ultrasound in Crohn's disease in Montreal. Okay, so it's come 22 years later, full circle. So I have trained one of my fellows. I sent them to Europe. We bought one of the new Samsung machines, and every patient every Monday is getting an ultrasound to benchmark at diagnosis. And then I do it after induction, and I do a Calpro and a CRP the same way Dave noted. And then I correlate it with my treatment target endoscope, because then I would like to follow them using ultrasound rather than multiple scopes. So I will tell you, it has changed my practice dramatically. And I hope we get this into more and more practices across the country.
Yeah, so you can't get the Canadian out of you for using ultrasound many years ago and now showing us how to do it here. One more quick question that came through as you were talking from a pediatric standpoint. There was a question on Ustekinumab in younger patients. Are you using this in your younger patient population? And then I'll do my part, and then we'll get back to some questions.
Sure. So, above the age of 2, we pretty well struggle with the same problems of adult onset, IBD. And to be fair, today I scoped 3 different Crohn's patients, and I switched all 3 to Ustekinumab. It's just, our TNFs are done. There's not much else left. And so for us in peds, Ustekinumab has actually worked better than in adults. And I think it's a dosing issue, because we're at, smaller weight and we're using the 90 milligram dose. So I think you'll see a lot more data coming out about peds, but it is my go-to. There's no question about it. Yeah.
Great. Well, thank you, Marla. Let's transition to the final learning objective, and then I'll engage Dave and Marla in more of these excellent questions that keep coming in. So the third learning objective is translating available efficacy data into real-world effectiveness. So let's go to the case, and let's meet Elena. Is a 36-year-old female with Crohn's disease. She has Crohn's ileitis diagnosed in 2016, who was originally treated with budesonide and 5 ASAs. Now she presents with diarrhea, weight loss, worsening abdominal pain. She does have a father with a lymphoma, so she's a little bit worried about side effects, and she has an aunt with Crohn's disease. You can see based on her laboratory data, her CRP is 9.4, hemoglobin 11.1, fecal calprotectin is high at over 3,000. She has a CAT scan that shows 15 centimeters of ileal disease. And a colonoscopy confirms ileitis and ulcers as well as anal-rectal ulcers. So Marla, to your point, she has anal-rectal disease consistent with Crohn's, and she's C. diff negative. So let's go to the audience response and ask a question. I want to see what our audience would do with this case. What would you do for the treatment of Elena? Would you A, anti-integrin, vedolizumab, B, anti-IL-12/23, ustekinumab, C, anti-TNF, infliximab, certolizumab, or adalimumab, or D, prednisone with thiopurines, or E, I don't know, tell me the answer. This has already been a discussion we've been having, and at the end, Dave and Marla, I'm going to be curious to hear how you position therapies. Marla, I was hearing, interestingly, based on that question, you're using ustekinumab, a little bit more even in your pediatric population, and finding this works. So I'd be curious when we get to the end how we approach this. So this is a systematic review that was done, and I would caution everybody that probably systematic reviews do not necessarily always correlate with clinical practice. However, these are some of the better data we have in terms of a first-line therapy. So when you consider first-line induction therapy for moderate to severe Crohn's, which included infliximab, adalimumab, certolizumab, vedolizumab, ustekinumab, and if you look at the black diamonds on the right, which favor experimental versus control, you can see that overall the effect size was positive for all treatments except for certolizumab compared to control. So if we move on and consider second-line therapies, so the question is, what about second line? More often our first-line therapy is an anti-TNF. This is another systematic review. And what you can see here, interestingly, is the effect size was positive for adalimumab and ustekinumab, but not necessarily vedolizumab. And interestingly, Marla, when you talked about your kids who are failing anti-TNF and do well with ustekinumab, you're already applying that as a second-line agent. But we need to consider safety. And safety always comes up as one of the factors in discussing this with patients. And you've seen the safety pyramid that Ben Click and I put together several years ago, and we're constantly updating this as we get more information. But if you consider the safety pyramid with safest on top and least safe on the bottom, and I should mention, by the way, you see in the box inadequate treatment is an adverse event. So if we think that combination anti-TNF and thiopurine is the best treatment, although it's lowest on the safety pyramid, we should still use it. However, if you look at the top of the pyramid, ustekinumab and vedolizumab hold that top slot. And I think that with accumulating data, we are seeing safety with both of those agents that is certainly superior to the others. Well, what about comparing vedolizumab to ustekinumab? Now, we don't have prospective data yet. We don't have head-to-head data, but there are some comparative effective data looking at this after anti-TNF. And if you look at the light blue bars are ustekinumab, the purple is vedolizumab, and this overall looks at the proportion of patients on the y-axis and looks at different weeks. And on the left-hand side is corticosteroid-free remission. The right-hand side is biochemical remission. And you can see generally you are seeing better rates or better responses with ustekinumab for corticosteroid-free remission, and at least early for ustekinumab and biochemical remission, but there's a bit of a flip-flop for vedolizumab at that week 52. Again, these are interesting data. They're not the be-all and end-all. But let's go to the effectiveness of ustekinumab as a dose escalation in Crohn's. And Dave, I'm going to ask you in a minute, since this came from the University of Chicago in your group, that this was an interesting study that looked at escalating therapy of ustekinumab from every 8-week dosing to every 4 weeks, and showing that shortening the interval improved both clinical and biologic indices of disease activity. So Dave, maybe since you were involved in this, you can kind of mention for a minute your thoughts on your study with ustekinumab escalation of dosing.
Yeah, I'm happy to, and thanks for asking. So we obviously had a huge number of patients on USTA at our place. And what we learned is that the people who did best with dose escalation were those who clearly had response to the first 2 doses of therapy. It doesn't mean they achieved remission necessarily, but they were clearly improving, or they were in remission and then lost response, and we dose escalated in that scenario. The people who were primary non-responders after a couple doses of drug did not do as well, and we tried to give them more drug. So the lesson there is, number one, that it's the responders that would benefit from more drug. And then the second thing we saw was that usually by the time you give 3 doses at your escalated schedule, if they're not captured and back under control, it's time to move on. So the criticism and limitation to our study, though, is we didn't have any PK data. We didn't have serum concentrations of drug. So we could predict what we think that it may have been, but we don't have it.
Yeah, and I think 2 other take-homes from a practical standpoint, probably a lot of the audience out there is finding what we find is sometimes that's hard to get paid for. The other interesting thing is at ACG, there was a study that took your concept of every 4 weeks, but also looked at every 6 weeks and found that there was a benefit at every 6 that seemed similar to every 4. So I think we're learning about this, and I think your take home of you need a response, and these are responders that have a better outcome when you escalate dosing. So
the STARDUST study I teased the audience with is going to show that as well. So we'll have those data, and I'm sure that's part of the message that needs to be communicated about when this is appropriate and whether it's cost effective.
I totally agree, and I think it'll be interesting to see those data. So stay tuned for STARDUST. I love that title. All right, so let's move on. So when we talk about anti-drug antibodies, I think we've seen this already in terms of the impact of dose escalation and risks of recurrence with switching in and out of class, which I think we should avoid switching too soon is a general message that I would say, unless we really feel that there's a loss of response. You've seen some of this before in terms of dose escalation with Infliximab based on a drug tolerant assay where the primary outcome was achieving an Infliximab level of over 5 or an adalimumab level of over 7.5 and undetectable antibodies. And more of the Infliximab treated patients actually met the primary outcome with and without dose escalation. Interestingly, none of the adalimumab treated patients met the primary outcome despite dose escalation. And then what about switching to a second anti-TNF if it was Infliximab then adalimumab or vice versa? Infliximab switching to adalimumab, about 28% of the cases developed antibodies to adalimumab. The adalimumab to Infliximab, 39% developed antibodies. So I think an important point, just to restate this, is if you've developed an antibody to one anti-TNF and you switch to the other anti-TNF, we are seeing a percentage of those patients who develop an antibody to the second. Interestingly, switching to Vedolizumab or Ustekinumab from an anti-TNF, there was no difference in the rate of antibodies for Usta or Vedolizumab antibodies. So my take home from this is if you've had a prior anti-TNF, have developed antibodies, while we can use a second anti-TNF, we are seeing an antibody formation to that second anti-TNF, where we don't see that when we switch to Vedolizumab or Ustekinumab. So combination therapy, Dave, you already talked about this, so I'm going to skim through this, but the SONIC study, Infliximab levels are probably more important than even combination. I think we're learning now if we achieve that right level and especially deep remission, that's better. We do not see benefit of combination with Ustekinumab or Vedolizumab, and that's been my practice to use monotherapy. We also see better safety, obviously, with that. And then 5-ASA, this may sound intuitive, but 5-ASA is not helpful when escalating TNF therapy. And there was actually studies at DDW showing that 5-ASAs were not only not effective, but not cost effective when we start a biologic or when we start an anti-TNF. What about optimizing response to biologics? So I think that patients with, and Dave, this was your question to me about our study and looking at surgeries, Short disease duration, patients did better. Starting a biologic, an anti-TNF, responded better. They had less loss of response, less surgery, as we talked about. And then the first therapy usually works the best. So if our first line is Vedolizumab or Ustekinumab, we're seeing benefit in bio-naive patients. So usually our first treatment is the best treatment. I should say that Ustekinumab used after anti-TNF did still show a benefit in Crohn's, where we didn't see the benefit with Vedolizumab second to anti-TNF. And then obviously we need to look at proactive drug monitoring. What about individualized therapy for moderate to severe Crohn's populations? There was actually a question that already came in on age. So over the age of 65, monotherapy Ustekinumab or Vedolizumab is effective and safe. If it's a patient who has limited Crohn's disease, or if they have no fistula, Vedolizumab and Ustekinumab certainly are quite reasonable. And Ustekinumab is also effective for small and large bowel Crohn's, where Vedolizumab, at least based on some of the data, may be more effective for colon, but not as much only small bowel Crohn's disease. Pregnancy, monoclonal antibodies in general are all fine. So anti-TNFs, Ustekinumab, Vedolizumab. Extraintestinal manifestations, certainly anti-TNFs and Ustekinumab. And then we already talked about patients failing anti-TNFs in the past. Let's spend a minute on fistulizing Crohn's and some of the other therapies. We know that anti-TNFs work for fistulizing Crohn's, but this is kind of a post hoc analysis looking at the efficacy of Vedolizumab in fistulizing Crohn's disease. And again, in purple here is Vedolizumab induction followed by maintenance. And then the gray is Vedolizumab induction followed by placebo. And you can see actually that the patients who continued on Vedolizumab did have benefit in fistula closure, even though this wasn't an a priori prospective endpoint. What about Ustekinumab for perianal Crohn's disease? And this is another nice study looking at actually fistula resolution at week 8 among patients randomized. These are open draining fistula, and these are pooled data from a number of the Ustekinumab studies. And you can interestingly see that especially at the higher doses, and when we look at all doses combined, there's a trend toward improvement with fistula healing. And then patients in fistula who had a fistula response, which is defined as over 50% reduction, looking out through 44 weeks on the right-hand side. This is the IM-UNITI study. You can actually see a separation of the lines between the subcutaneous Ustekinumab versus the placebo. So we are seeing benefit. Let's switch gears entirely to talk about something that comes up probably 10 times a day, which is COVID, and talk a little bit about COVID because I think we're probably going to get some questions on this as well. And how do we manage COVID? And Dave, maybe when we get to the Q&A, I know you were first author on this really important work. And these are looking at COVID and symptoms or findings suggestive of COVID and those that have testing. And then how do we consider whether they're test positive for SARS-CoV-2 or negative for SARS-CoV-2? And more importantly, which one actually have COVID symptoms? So those that are asymptomatic for SARS-CoV-2 are obviously different than those that have symptoms with SARS-CoV-2. And I was asked today, why do we see asymptomatic SARS-CoV-2? Well, two things. One, we're starting to test our general population more. So those going off to school or college or for different reasons. So we're picking up asymptomatic. And two, one of, I think, the interesting and scary things about this virus and this pandemic is there are many people walking around with COVID, or I should say SARS-CoV-2, who are asymptomatic. So we should consider IBD relapse that's unrelated to COVID-2. We need to confirm inflammation by non-endoscopic approaches, although with COVID-19, fecal calprotectin can actually go up. And then for moderate to severe Crohn's, generally I'm treating these patients the same as we normally would. But what about patients who have symptoms of COVID-19 and are positive for SARS-CoV-2? This is probably the group we worry about the most. Well, we do normal things normally. We always want to taper prednisone. That's true of anybody. We generally continue 5-ASAs, although we can get into the secure registry and some of the very new data suggesting 5-ASA saw an association. But generally 5-ASAs are therapies we continue. Thiopurines, methotrexate, tofacitinib, biologics, generally we hold those agents, especially if somebody's sick, but then we need to weigh the risk and benefit of the IBD with the actual COVID. Usually we wait 72 hours for fever resolution and about 2 weeks for COVID symptoms to resolve before resuming therapies. Maybe we can summarize some of the treatment decisions that we look at for COVID. So I think first, real world data support efficacy and safety of biologics in the treatment of Crohn's disease. The second is response to therapy is individual and should be optimized based on available data and patient characteristics. And then finally, during the COVID-19 pandemic, biologics should be continued. We should not stop our treatments just because people are walking around in the world of COVID. If they do develop SARS-CoV-2, but they're asymptomatic, they don't have symptoms of COVID-19, generally we are holding our immunosuppressive therapies, but some of them are not due for their next injection or infusion. So if they're doing well for 3 to 5 days and they don't have symptoms, I think it's okay to continue. If they have COVID-19 symptoms, we are holding until the fever is resolved. So let's get back to our discussion and maybe our patients and see now what the audience would do in terms of next steps. And then Marla and Dave, maybe I can ask you a few questions along the way. So let's recall our first patient, Charles. And Charles, a 23-year-old sudden onset of GI symptoms who ends up having what looks to be moderate to severe Crohn's disease. And the question is, he had been on a 2-week course of prednisone. Now what would you do? So A, would you taper off prednisone, start methotrexate? B, taper off prednisone, start an anti-TNF with or without thiopurine? Stop prednisone, anti-integrin? D, stop prednisone, anti-IL-12/23? Or E, do you still not know, and tell me the answer? So actually, Marla, let me ask you while we wait for the audience response. In this new onset 23-year-old Crohn's disease, moderate to severe, what's your first line go-to agent?
Yes. So, for me, I'll be honest, a patient who has significant ileal disease with a high CRP, and again, talked about the ulcerations, my first choice would be an anti-TNF. I do feel very strongly that for especially small bowel disease, that I think the data supports anti-TNF as our first line approach. Now, again, we may find when we see mucosal healing data from STARDUST and from any other Ustekinumab studies, we may think differently, but right now the data does support anti-TNF for the best mucosal healing outcomes.
So Dave, the poll just popped up, and Marla, you kind of hit it. I think the audience is still favoring anti-TNF, but the STARDUST information, the Ustekinumab information, there seemed to be a greater uptick in terms of the IL-12/23 Ustekinumab. Any comments on this poll result before we go on to the next one?
I don't disagree with Marla, as always, but I think the IL-23 choice is reasonable as well. I have a patient who's almost identical to this one that I saw last week as a new diagnosis of Crohn's. And in discussions with her, we ended up moving towards Ustekinumab. But of course, with anti-TNF, we know more about how to optimize it early and how to assess response early. So we have more data to guide us. Perhaps the STARDUST study will give us the information we need. So I think that there wasn't a wrong answer in those two choices here. The key, as I mentioned, is moving through it if it doesn't get you what you need early enough. Don't let people languish on a therapy that's not doing its job.
Yeah, I also, can I just make a comment about what Dave said about drug monitoring, that of course with TNF, we understand induction levels and early maintenance. We need to understand that a little bit better, for example, with Ustekinumab, because maybe there is a dosing issue. Have we maximized the dose? Are there better ways to induce? We haven't figured that out the same way we have TNF. So for me, I feel this like a comfort level of knowing what my target is. So I think that does bias me a little bit. But I think what's really exciting is the next generation of IL-23. To be fair, we're starting to see from the phase 2, we saw some early mucosal healing data, which I think was exciting. And also, as we move into some of the JAK1s, and we know also mucosal healing and induction. So I think this is the beginning of our dialogue to say that right now the data is best with anti-TNF, but that is, I think, going to change as we see our new therapies coming to market.
Yeah, and just for the audience to clarify, the second generation IL-23s don't hit IL-12. They're P19 inhibitors, so they're pure IL-23s. And in plaque psoriasis, they have been head-to-head better than IL-12/23. So there may be that same benefit with Crohn's.
And I should probably note just that Janssen themselves are having in their phase 3, they're doing a head-to-head of the IL-23 versus IL-12/23. So that should speak to the fact that maybe we're even going to get more specific. And this class of drugs is going to be very effective for our patients first line.
We need to move on. This is great. And so I think we're seeing exciting data with selectivity and also S1Ps, which we haven't even talked about. So let's go to the next case. This is Elizabeth, 25-year-old, diagnosed with Crohn's, recently ileocolonic, abdominal pain, high CRP, and again, a colonoscopy shows deep linear ulcerations in the ileum and right colon. So let's go to the choices again. And again, same kind of scenario. Which biologic would you choose first? Anti-TNF, anti-IL-12/23, which currently is Ustekinumab, anti-integrin, which is Vedolizumab, or D, you still don't know. So one thing that was good on the last poll I should mention is more people knew what they wanted at the end. So I guess Marla and Dave, at least we taught a percentage of the population. So Dave, maybe as people chime in with their result and their answer, what would you choose? You kind of said it already, but what would you choose for Elizabeth?
Okay. I mean, when we were initially discussing this symposium, I think the first point was to say this patient needed a biologic therapy. We shouldn't just jump to that without at least commenting that that's the right choice for a patient with this moderate to severe disease. We need to just get with the program, and we've learned that treating early changes outcomes, as you've shown and I've shown and other studies now support. So that's number one. Number two would be that whatever therapy I'm going to use at 6 weeks, I'm going to assess objectively to know if we're getting what we want out of it. If I was going to choose an anti-TNF, my preference in this patient would probably be adalimumab or Infliximab over Certolizumab. And if I was choosing one of the other drugs, it would probably be Ustekinumab. But I have patients with more luminal and more the moderate side of disease that I use Vedo in. I'm not trying to hedge. I think the reality is this is where we are.
Yeah, and we have to have obviously discussion with the patient, IV, sub-Q, safety. So Marla, let's look at what our audience did, and maybe I'll have you respond to this. So the blue is pre, the green is post. Looks like there's actually a big uptick for Ustekinumab. Fortunately, the 22% on the right that didn't know all know now. Said a little bit of a downtick for anti-TNF. Are you surprised by this, Marla, or any comments?
Yeah, I mean, I still stick with my deep ulcers in the ileum, CRP 26. I'm not budging. I'm glad that we brought the role of Ustekinumab out as a Crohn's option. Don't get me wrong, but I really do feel that we need more mucosal healing data to be able to say whether or not SC-SCD or the scoring of the endoscopy is significantly changed when you're using Ustekinumab. Reality is that when a patient is sitting in front of you, so many different reasons come into play. So I'm traveling.
Therapy, right?
Huh?
Being able to get it from their insurance is important.
That's a whole other problem. But yeah, the fantasy of getting everything, fine, you're right. The whole idea of fail first and all that nonsense that we sometimes have to deal with. I just say, a woman, so one of the questions that people ask me, do I use Certolizumab over adalimumab or Infliximab in a woman, let's say she wanted to get pregnant? I don't. I go with the drug that has the right dosing, that is the most effective, given what you noted, Miguel, that the first trimester, none of the biologics cross. So we're in a good place when it comes to organogenesis. So I am sticking with my anti-TNF for the moment in this region.
It's not wrong. And
It's not, yeah,
I like that nobody felt unsure at the end. We got people
Yeah.
to move
that's
toward.
that's what I said. The good thing is we got 22% recovered. All right, let's go to the last one. Then we'll go to some SMART goals, and then we'll have a few minutes for questions. So Elena is a 36-year-old Crohn's, father with lymphoma. Again, you can see moderate to severe. Let's pull up the polling questions, because I think we're seeing a theme here. And kind of same approach: anti-integrin, anti-L1223, anti-TNF, prednisone and thiopurines, or E, I don't know. Maybe Dave, I'll ask this differently. Is D, prednisone and thiopurines, now an incorrect choice?
Well, we know that when there's a first degree family member with lymphoma, the risk of lymphoma, regardless of therapy, is already twice as high, the relative risk. So then to add the thiopurine as that option there, I think is not what I would choose, given that we've seen that there's obviously a relationship. So that one would be off my list. So I think D wouldn't be right.
And then Marla, probably you would say the same as last time, that an anti-TNF is reasonable, probably combination, versus any of them would be probably okay. So Marla, here we go. Kind of the same, a little bit of an uptick for IL-23. Anti-TNF is the third choice, which about a third chose. Fortunately,
Safety of veto here, right?
Yep, and I was going to say the veto picked up because of the father's history of lymphoma. So I think we've talked about these. Let's go to the SMART goals and then get to some of the questions. So this was a great discussion. Now let's provide these SMART goals. We should use clinical decision tools before initiating treatment. All of us have talked about early initiation of treatment and the treat to target and tight control. And then we're learning more about our real world data when we select these therapies. So now some time for question and answers. And I think what I'm going to do at this point is we're going to do quick hits, because we have so many questions as usual and just not enough time. So there's one specifically for you, Dave, and let's try to keep these focused. I've heard you say in other talks we take too long to taper prednisone. What's your tapering strategy?
Well, remember that we taper prednisone first to stabilize the patient while we're waiting for a steroid-sparing therapy to be at the appropriate concentration for long enough to do its job. We less often taper, despite what everyone thinks, because of a risk of adrenal insufficiency. That's rare, especially when we use steroids the way we're supposed to. And it is a fallacy to think that the slower you taper, the more likely you'll succeed, like you can tiptoe away from the disease.
Mm-hmm.
So I think that you need to assess the disease, like we've talked about. When the patient's stable and you've had them loaded or have received the first couple doses of their new therapy, it's time to move them off steroids and try to get them down.
Yeah, and so generally I favor similar. I think we all practice the same, where I usually start at 40 of prednisone, give it a week or two, but try to keep them to 8 to 12 weeks. But again, everybody's personalizing what we do.
We published a study where we showed that if the Calpro was less than 200, and certainly when it was less than 100, you were more successful getting them off the steroids, which makes good sense, right? The bowel is healing or healed, and you were going to.
There were a lot of questions on biologic cross-reactivity to antibody or antibody formation. We kind of said that, but I'll just restate it. The data looked that if you develop an antibody to one anti-TNF, it's more likely with the second anti-TNF. However, if you develop an antibody to one anti-TNF, Vedolizumab and Ustekinumab don't seem to form antibodies. So I think that's a simple question that I'm going to leave there. Marla, there are a lot of Ustekinumab questions in adults and kids. You've kind of talked about this already, but there's one question or a bunch of questions on small bowel Crohn's versus colonic Crohn's. small bowel versus colonic, ustekinumab versus Vedo. We've kind of talked about this a little bit, but what are your thoughts?
Yeah, I mean, that's an amazing question. You know, we're all thinking about, is our treatment strategies solely based on location at the end of the day? Maybe that is as simple as it will get. Obviously, it's much more complicated from a biologic perspective, understanding the biology of small bowel versus colonic disease. I did want to make a clear distinction. In someone with very deep rectal ulcerations, that is not the same patient where, in my opinion, vedolizumab and maybe ustekinumab would be effective. I wanted to highlight that because, like you said, I say when you have one of something, you got to get yourself together here. And I use infliximab actually in patients with, because they end up with an ostomy and stricturing anal rectal strictures. So I am like a beast when it comes to that, especially in
You're always a beast, Marla.
But like
not just that.
I beasted up. So the idea that I become even more obsessed on that. So, but I do believe, and I say this all the time, I do believe that vedolizumab and ustekinumab from a biologic perspective, looking at IL-23 in the colon, IL-17 pathways in Vedo, I do believe that they are better in the colon, in my opinion, than the small bowel. Not to say they don't work in the small bowel. I'm sure that's where you saw my obsession with TNF and small bowel. That's my separator in my decision making. Yes.
So I agree. Even though you're still a beast. All right. Question on mesenchymal stem cells. I'm going to take that briefly because Amy Leitner, colorectal surgeon's here with us at Cleveland Clinic. And I think that's primarily being focused on fistulizing perianal fistula without severe rectal inflammation. That's the bottom line. We need more data here, but in Europe and Spain specifically, there have been good data. Dave, we only have about 2 or 3 minutes, and this is one that's going to be hard to answer quickly, but there are a lot of questions on how do you escalate ustekinumab and vedolizumab, and do you ever de-escalate? So big topics, maybe.
I'll cover it quickly.
Yep.
You can increase the dose by decreasing the interval because you can't necessarily give more drug at the same interval like we do with the anti-TNF. So that means going to 4-week intervals, reassess after 3 doses. If you're not where you think you are, this is true for Usta and for Vedo and frankly for other anti-TNF, you move on. So have a way to assess the disease, plan it, and obviously if they're getting worse while you're doing this, you're going to need to do something else.
I do want to comment that at DDW, there was a really good abstract that was presented prospectively looking at week 52 mucosal healing with ustekinumab and showed that at the week 8, your first interval, if the level was less than 9, you had a significant reduction in being in a healed state. So already we're starting to look at early levels to maybe drive dose escalation. So don't give up on figuring out a post-induction level.
Yeah, and then the only final thing I'll mention, there are a bunch of questions on initial dosing of Infliximab. And I think many of us, and Dave, you could talk about cyclosporin at a different time and linking to Vedo, but many of us are starting 10 milligram per kilogram, even though the long-term colectomy data for severe sick inpatients isn't there. Because their albumin's low, they are clearing it. They have this TNF sink. So with that, and I apologize, we don't have more time for questions, but just maybe I'll recap. So to receive CMEC credits for today's program, complete the post-test and print your certificate. Dave and Marla, these were great discussions. Now let me provide these SMART goals as I would like to give the audience from today's program. And then I'm just going to close out by wanting to remind everybody to visit cmeoutfitters.com to access this presentation. Again, I want to thank both Dave and Marla. I always enjoy doing these with you. I learn a lot from you. I think we also share a lot of the same interests and goals. So thank you for being with me. And I also want to thank CME Outfitters for their assistance in developing today's program. They did a great job transitioning what was going to be a live meeting, and we're sorry we're not all together, but given the hundreds of people that logged in, we actually think we probably reached more people this way. So stay safe, stay well. We know it's a scary time in the world, but we hope everybody's well, and we hope to see everybody soon in person, hopefully in 2021. So have a good night. Marla and Dave, thanks again.
Have a good night.
Bye, Marla.
Bye.